So what can there be left to say after the consummate presentation on the left side? But there are some features of right-sided endocarditis which are distinct, and it's worth examining them. If we start by this, again from the group from Madrid, this data examining the differences between patients presenting with native right-sided endocarditis and native left-sided endocarditis, there are some very key differences. Right-sided endocarditis patients tend to be younger, slightly more male, heavily more intravenous drug abusers, and they're much more likely to have staphylococcal or coagulase negative staph, so skin commensal type of organisms. They're more likely to have pulmonary thromboembolism. They're going to have bigger vegetations, but the key is they're going to be much less likely to develop periannular complications such as abscess or fistula, and importantly, their in-hospital mortality is surprisingly low. So we're left, I would just restate what the first two speakers have both said, which is whenever doing an echo talk, one has to put up a health warning to say that you don't diagnose endocarditis with echocardiography. It's a fantastic tool for confirming the diagnosis and potentially identifying cases from time to time, but the diagnosis remains a clinical diagnosis backed up by microbiology. So we're going to be dealing with two basic syndromes, although of course you could extend this, and the first is a general surprise, really, which is we have a slightly good news story here. We have this poor character who doesn't look like they're good news, but in fact, in terms of their mortality from this index case of endocarditis, they do quite well. And similarly, our traditional friends in the intensive care unit and the operating theatre with their long lines are introducing infection, but the outcome from the disease is relatively good. So bacteremia-type induced endocarditis has a mortality which is relatively low, between 5 and 10%, depending on which part of the literature you read. And particularly, as I can see his dad in the corner, I have to apologize, he does know it's here, my dear colleague, Dr. Patel here, who is a consummate implanter of cardiac devices, and I would trust him with my life and let him put my device in. But this scenario is people, through trying to do good, are indeed creating a problem periodically in about 0.03 to 3% of people where you get device-related infection and particularly device-related endocarditis. And this has a much higher mortality than that of the staphylococcal variety injected directly into the circulation. Now you hear quite a lot spoken about the fact that on the right side, transesophageal echo is not as sensitive as it is on the left. And there are various reasons for that. Here you can see a back-to-back case of a patient who fortuitously had a TOE last week because of enterococcal sepsis, having spent some time on ITU. The TOE is over here on the left, and I hope you can agree you can see the intraatrial septum quite nicely. You can see a bit of the aortic valve here, but not much. But you can't see much down here where the pulmonary valve sits. On the other hand, the transthoracic echo shows the aortic valve here in reverse, and the pulmonary valve you can see, it's a bit jerky, but hopefully you can see the vegetation whipping around on the pulmonary valve there. And the reason for these are numerous. Firstly, the probe is sitting much closer to the right-sided structures. And secondly, these patients, particularly those that are young and have been intravenous drug abusers, are quite thin and have nice echo windows. And finally, you can get a lot of reflection from the central bodies of the heart, such as the aortic valve, which can obscure the structures beneath. So if we look at the data, if there's little data in left-sided endocarditis, I can assure you there's even less in right-sided endocarditis. And this, again, is an old paper from 1994, basically prehistory in terms of echocardiography. But that did show that across the board, you got a similar diagnostic pickup from transthoracic and transesophageal echo. But there is little direct comparison, and I think you have to look at a pragmatic approach here. There are areas of the heart that are very badly imaged by transthoracic echo, such as the eustachian valve, which represents 3% of right-sided endocarditis. And also, there is, of course, the risk that you get left-sided involvement, which you know already is not going to be so well demonstrated from transthoracic echo. So it rather depends on the patient in front of you. A very low-risk patient with good echo windows and suspected right-sided endocarditis, perhaps transthoracic echo is enough, but by and large, a TOE is sensible. So, as Tom said before, the purposes of the examination is to make the diagnosis, to establish the complications and to establish the extent of valve dysfunction. But from an echo point of view, it is very important that certain views which you would not normally perhaps optimize as part of the examination are carried out in some detail. The first of this is the parasternal long axis view, where the probe has been angled inferiorly to demonstrate the tricuspid valve, but also the os of the coronary sinus and the inferior vena cava, the position of the Thebesian and Eustachian valves, which of course could be a sanctuary site for endocarditis. And here I hope we'll see not, I'm afraid, a Eustachian valve vegetation, but certainly one on the tricuspid valve, seen quite satisfactorily from the transthoracic view. The same is true for a superior angle of the pulmonary outflow tract, which again needs to be imaged in two views, particularly focusing on these valves. I mean, this is part of a normal data set, but you will see in a standard echo data set that perhaps these views are not optimized as well as they might be. This is a homograph here in the pulmonary outflow tract position, and as you can see, it's in quite considerable trouble. The standard four-chamber view, but altered and optimized to look at the right side of the heart. Here again, a vegetation attached to the septal leaflet of the tricuspid valve, and of course the subcostal view, which is a very important view for right-sided structures. Turning to the transesophageal view, and another view which is not done as often as it ought to be, this is a transesophageal transgastric view optimized by a quarter turn to show the right-sided structures, and you see a really nice long axis of the heart which shows very clearly the caudal structures. Here again the septal and either the anterior or posterior leaflet, difficult to tell, a vegetation there, and with a little bit of optimization you can even bring the pulmonary valve in that view and bring it round to a short axis view. And then finally, a view which is of critical importance because it's the view that shows the superior vena cava, the inferior vena cava, and its junction of the Eustachian valve here, and one, again, which needs to be undertaken in all cases quite carefully. And I hope you can see this malplaced line coming through the superior vena cava and banging somewhere into the bottom of the right atrium. This is an example of exactly such a case from a paper from Rachel James some years ago, and that's a modification of the same view, the inferior vena cava there, and you can see this rather large vegetation attached onto the Eustachian valve there. Extremely easy to miss in a patient, for instance, with staphylococcal septicemia. Now, there is another problem on the right, which is perhaps more prevalent on the right than it is on the left, which is the problems of misdiagnosis. This patient came in with a fever and a bit of an infarction and had this horrible thing sat at the back of the right atrium, which is in fact a very typical crista terminalis, which has got lipomatous infiltration, which you can demonstrate if you want to with CT quite nicely. This is perfusion here in the septum, and this is bound in the interatrial septum, and that's quite well demonstrated, but again can give you a nasty shock in the acute setting. Similarly, this is a rather florid Eustachian valve. You can see it floating around here, but that could easily be misdiagnosed as vegetation. A Chiari network is a more advanced version of the same, and you can see a lot of echoes floating around in the right atrium there. Apology, no movie. So there are a lot of things you can misdiagnose as vegetations in that scenario. Now, this is an echo talk, but I think one has to broaden it slightly to imaging, and even simple imaging like a chest x-ray, because one of the key factors in right-sided endocarditis is the presence of pulmonary complications. Chest syndromes are not only common, they're almost inevitable. And an abnormal chest x-ray is an important finding in diagnosing right-sided endocarditis, as is an abnormal CT. It does help make the diagnosis in difficult cases where the imaging has perhaps let you down a bit, and it may again be helpful in defining treatment failure if you're seeing ongoing pulmonary abscesses despite medical therapy. So where specifically might echo help us in perhaps prognosticating and speaking with our cardiac surgeons or our explanting physicians? Well, certainly a large vegetation above 2 centimeters is associated with a very poor prognosis, and therefore that is a surgical discussion. Similarly, if you have multiple ongoing pulmonary infarctions or abscesses despite your initial therapy, that is a surgical discussion. If your valve is falling to bits, as in the case of this homograft, and you have this poor girl went into quite florid right heart failure secondary to acute severe pulmonary regurgitation. And finally, if you've got bacteria all over your heart, so here's a really nasty case of a left and a right-sided endocarditis where the endocarditis has come over the mitral valve through the aortic route and is also affecting the tricuspid valve there in its septal leaflet. So those are all surgical consults. Moving now to the second set of symptoms, which is the second syndrome, which is pacemaker lead endocarditis. And here we see a rather different pattern. The evidence is quite clear that transthoracic echo is insufficient for diagnosing suspected pacemaker lead endocarditis. And on transesophageal echo, which you must do, there are 4 patterns. As mentioned before, the normal appearances. You can see multiple small echoes, or you can see a single large lobular echoes, or you can see rather unusual looking floating strips within the, in relation to the pacemaker leads. It's worth mentioning that although the sensitivity with transesophageal echo is very high, the specificity is much lower because you can see a lot of these appearances in normal pacemaker leads or leads with thrombosis or some fibrinous degeneration. So it is even more important to get the microbiology and the clinical diagnosis right in this circumstance. Here's an example, one of the 3D transesophageal echo of one of these fibrinous strips, in this case an endocarditis on a large lead. This is a large defibrillator lead coming into the septum there, and in this example you can see the more localized vegetation. Now, from a technique point of view, there are 2 or 3 techniques which are very helpful in pacemaker lead endocarditis, one of which is a very old example, which is this, an old technique, which is to do sweeps. It's something in adult echo we've perhaps not done as much as we ought to. The pediatric echocardiographers are much better at it. If you look at this view, this is a patient who'd had an explanted device which hadn't been an unmitigated success. And I'll just wait for it to run back to the top. So we're going to look at the superior vena cava here, and the lead comes in, and suddenly you can see a white blobby bit. Now this is your suspected vegetation here, and then as you come up the pulmonary outflow tract, you see something that looks most unhealthy. So using that strip gives you immediately a sort of a more rounded feeling of what's going on with the lead, but you do need other techniques, and here more modern techniques such as simultaneous biplane. Here on a Phillips system, here you can see the vegetation of the same patient interrogated in 2 different views, and while it's not particularly useful in the short axis, modified short axis view, it's very helpful in the long axis view, and you can see the vegetation prolapsing through the tricuspid valve. And finally, it's a really good example where 3-dimensional echo can be really helpful. So this pigtail disappearing through the pulmonary valve, we're looking down from the pulmonary arteries here through the pulmonary valve, is the remnant of the lead, which clearly wasn't a huge success as a procedure, and you can see that curling around. But if you look at the entire 3D picture, you can see the left side of the heart here with the mitral valve, but you can see this lead remnant on this side going up the pulmonary outflow tract, and here you can see the vegetation on the right, going up through the tricuspid valve. So 3-dimensional echo can also be really helpful in trying to sort out some of these conundrums. This again is an echo talk, but I can't stop without talking about PET-CT because it's so much the imaging modality of the moment, and there are a number of papers. This is a good one from Jack quite recently showing a very high sensitivity for pacemaker-related infection, either, as in this case, within the box or potentially within the leads of the heart in patients with suspected endocarditis. But it is worth taking a health check here. This is done in highly specialized centers, and not only that, if you look at the literature in more general, it's extremely good at box, but whether it's quite as sensitive at lead as it's been billed in the past is difficult to say. I'm going to gloss over that because Thomas used the same penultimate slide as me. We'd obviously coordinated well there, and move on to some conclusions. So in conclusion, the clinical likelihood should define the imaging strategy, and the clinical likelihood and the microbiology remains key to the diagnosis. Transthoracic echo has a high sensitivity for native right-sided endocarditis, but a low sensitivity for pacemaker lead endocarditis. Vegetation side, lead involvement, and abscess formations are all indications for surgery or explantation. And TTE should be used in most routinely during the follow-up to look for signs of progression. And finally, PET-CT is an interesting tool, but it is really not prime time except in selected cases at present. Thank you.